All right, good morning, everyone. Welcome to High Rounds today. We have the pleasure to have Dr. Rehan Syed, one of our awesome fellows, who's going to present to us today about updates in pulmonary tuberculosis treatment progress and looking to the future. So we look forward to his presentation. Go ahead, Rehan.
Thank you. Yeah, so for this presentation, I was initially focusing on basically everything that's new in TB, but I realized to understand what's new in TB and kind of get a sense of where things are going, it's helpful to also talk a little bit about the history of TB and where we've been. So for the first part, I'll talk a little bit about just the historic background of TB. I want to talk a little bit about TB as a disease currently in the US, California specifically, and also globally. And then I'll start comparing some of the new updates in the last couple of years, as well as some that are seemingly in the pipeline. And, and that should conclude the day. If we have time, I'd really like to talk a little about the new diagnostics that are kind of coming up as well, but we'll see if I get to it in time. So just to open up, let's take a large step back, walk through memory lane, more like historic human civilization memory lane. And TB has been around for probably millions of years. There's been lots of different discussions about where it's come from. There have been conjectures that it came from domestication of cattle and M. bovis, which is another species in the MTB complex, which I'll sort of clarify in a little bit. That may not in the end be true, there's some controversy, but regardless, it's been around with humans for much of recorded human history. The word tuberculosis was coined in 1834, but you'll see lots of names throughout history. I think a lot of us may have been read about consumption in literature, and that was a word being used concurrently even after tuberculosis had been named. Phthisis is in the Greek literature, and you'll even see a lot of the modern words in, for example, Romanian and other languages come from some of these other names for tuberculosis. So it has quite a bit of a history. And it's thought that the first infection of TB, at least that we know of, was identified in a now submerged city off the coast of Israel in Atlat Yam. And it's kind of an interesting story. I won't go through all of it again for the sake of time, but they were able to identify this mother and child, did PCR testing, and confirmed tuberculosis using PCR testing in both individuals, which I think is kind of amazing that that's still possible. But it's been something that's been affecting humans for many years. It's been recorded in ancient Indian, Chinese, other civilizations' writings for thousands of years. And what you'll see in a lot of the literature is to focus on in Europe and the US, particularly because that's where we get a lot of our medical literature. But it's been a huge problem, as most of us know, throughout the 1600s to 1800s, where a quarter of all deaths were attributable to TB. World TB Day comes around every March 24th, and some of you may have seen signs for it or notifications for it just last month. And this is because Dr. Robert Koch discovered the bacteria at that time, and he was trying to find different ways to view it. And bacteria is acid fast, and it was not identifiable by conventional standards. So the painting on the right, or the drawings on the right, are his description of the bacteria for the first time. Ultimately, it was such a major disease that initially it was just dealt with sort of as almost like a contagion. It was everywhere. But ultimately, as management improved and was better understood, the New York Health City Department started to conduct surveillance. The CDC, of course, now does surveillance in most countries, have national TB programs that do surveillance as well as treatment and management. Now, we're going to talk a lot about antibiotics today, but I think it's really important to recognize that really until the middle of the 1900s, there were no great treatments for TB. Initially, there was the idea that it was just rest, food, and fresh air, ventilation was important. This is where all the sanatoriums came up. The first ones were built in England and in Germany, but in the US, believe the first one was built in Asheville, North Carolina, and then shortly thereafter by a physician who was suffering from TB in upstate New York, and he ended up developing the first TB research lab in New York and ultimately succumbed from the disease. And these continued to be built throughout, and mostly through the 1950s and 60s. At that point, treatments became available, and they were generally no longer useful or turned into general hospitals. I think at this point, this may be historical enough that many of us were not taught this, but Waxman, Bugey, and Schatz discovered streptomycin in the 1940s. This was the first aminoglycoside that was discovered, and it was effective against TB. Waxman received the Nobel Prize in 1952. This did cause some controversy in terms of who truly helped with the discovery, as these things tend to happen. But that's not the point of today's conversation. But let's just say that was the start of TB treatment. Resistance was observed, and ultimately, pretty rapidly, new regimens were developed and put into use. And initially, treatment was started in these sanatoriums, but in the 1950s, and this is the bulletin from 1959 showing the results of this study, in Madras, they looked at patients who were treated at home with isoniazid and sodium PAS versus in a sanatorium, and they found that the outcomes were similar. And so this is the big transition to treatment of TB at home. So pretty massive changes within just a couple of decades. And then as a result of this, part of just good public health management, but also treatment, you can see, this is just the US on the right, you can see a massive drop in TB mortality within the US population. But it remains the case that TB is a major worldwide problem. I think most of us are aware. And the reason why I think, I think of TB as part of coinciding with the HIV epidemic as well, just because co-infection is such a major issue. So, today I'll be talking specifically about TB, but it's important to keep in mind, in the back of your mind, throughout this whole talk, that a lot of times we're talking about people who are co-infected with both, and how relevant that is. I also want to make a quick note on nomenclature. You'll see some inconsistencies today just because different articles, different resources use different words. Very traditionally, and I think for the most part, I'm sticking to this just because I think this is what people will be familiar with. Latent TB was called, which is abbreviated as LTBI, is TB disease that is not clinically active, but your body's been exposed to it. So this is like a positive skin test or positive quantiferin, for example, whereas active TB is TB that is clinically active. This could be signs, symptoms, positive sputum, etc. Now, the changes that are occurring is that there is a move to call latent TB as TB infection and active TB as TB disease. So you will see some resources referring to it as that. You might see in some of the slides and some of the tables, for example. So just keep in mind that that's sort of a change that's in progress, and you will see inconsistencies in the current literature. And if you notice in this presentation, that's why, but also feel free to ask questions if that's at all confusing at any point. I'll try to keep it as clear as possible. So let's talk about where TB is right now and kind of why we're having to see all these rapid changes. Because keep in mind, TB was sort of massively changing in the 50s, 60s, and then really through like the 80s, 70s, 80s onward, there has been movement, there have been improvements. Of course, you can see the decrease in the number of cases, but recently with COVID-19, we've seen some backtracking, and we've also suddenly seen, coincidentally, just around the same time, new treatments, new diagnostics come out that have been major changes after having almost 40 years of stagnation to some extent in terms of our methods. So let's start with TB in the US, because I think that's what a lot of people will be interested in, and then we'll move outside the US. A total of 8,300 new cases reported in the US in 2022. That number may seem very low to everyone, and it is quite low in my mind when you're looking at worldwide numbers, but it's still pretty significant given the extraordinary effort a lot of public health departments put in to try to push down the incidence of TB towards the goal of elimination. And keep in mind, California is by far the highest, has the highest incidence of TB. And in particular, places like San Diego, right, with our active border, we see a good proportion of that. In total, there were about 600 TB deaths in 2020. I couldn't find, there are some more recent numbers, but that's the one that seemed to be the most reliable. And then a trend that's been, you'll see in some of these slides, but also sort of worldwide, there's been a decrease in incidence, a decrease in basically all the metrics for TB, somewhat slowing recently. And then from 2020 onward, you definitely see a sort of a backpedaling, worsening in the numbers. And just now we're trying to see more reporting of TB after what was probably underreporting during 2020 and 2021. So you can see that here again, it's kind of like a very small blip. This is 2021. You can see like slight uptick at the end, but this is the number of cases from the 1980s till 2021, and you can see that we're still far above what we consider the elimination threshold, or that's kind of where we need to get if we're to truly eliminate TB from the US. This is the percentage of HIV co-infection in the United States, which is, again, proportionally lower than some other countries. Just keep that in mind, distributed by age. But good news is that all of those are coming down in time. Some degree of that is also improvement in terms of our strides that we're making in terms of the HIV epidemic. So, and then in California, as I said, this is the place where we see the most TB in all of the US in terms of states. And you can see there's a slight uptick recently. This is probably, some people say this may be undercounting just because of you can see the number of reported cases between 2018, 2019, and 2020. There's like that drop and a small uptick. And the reality is probably that number is higher, but it's hard to say for sure. Maybe there may be underreporting. It's important to know that most of these cases in the US are progression from LTBI to active TB. And it's only about 10% are from transmission recently. The important part I think to recognize when you're seeing patients and also just looking at the situation in the US in terms of disparities, there really is a big disparity between Asian, especially Asian, Hispanic, but also Black patients who are coming in and having new TB diagnoses. The likelihood is much higher than white. Now, of course, part of this is going to be related to where these individuals are coming from and the local prevalence from their origin countries. So that is an area that is certainly a focus going forward. Luckily, in terms of drug-resistant TB, less than 1% of the cases are MDR TB or multi-drug resistant, and there are only 3 extensively drug-resistant or XDR cases from 2017 till present. So very few. Globally, the situation is a little different. It's estimated that around 25% of the global population has been infected with TB. That number persists, and about 5 to 10% of these will probably go on to develop TB disease. So that's basically 25% of the world population is LTBI and could progress to have active TB. It's important to know that people with HIV are much higher likely to develop TB disease, and the mortality without treatment is much higher in people living with HIV. The estimates are pretty wide out there, but I usually find around 90 to 95% compared to what is, again, a wide range of those without HIV, up to 85% in some cohorts prior to the treatment, start of treatment of TB with streptomycin, et cetera. But usually it's considered more around the 45 to 50%. So almost double mortality. It's also important to note that TB is the second leading infectious disease cause. It was the first until COVID came around, and 13 leading causes of death worldwide, but certainly one of the most preventative causes of death. And in 2020, the WHO global report, TB report came out in 2022 with data from 2021, with 1.6 million people having estimated to have died from TB in 2021, and that number is up from prior. And between 2020 and 2021, those are the first 2 years where we see an increase after really decades of decrease. So unfortunately, again, there's this kind of sense that we're sliding back a little bit. Drug resistance is an area that I'm pretty interested in, but probably isn't the focus of today's talk. But I just want to make a big point that this drug resistance is highly variable depending on which region we're talking about. The WHO has specific regions, but within the regions, it's also very country specific. A lot of the regions have less than 4% rates of MDR-TB, but especially in the European region, there's an estimated 26% of MDR-TB, but this is heavily weighted by the Russian Federation, Eastern European countries, a lot of especially post-Soviet bloc countries, and a number of Central Asian countries. The good news is that treatment success for drug-resistant TB is improving. I'll show some of that in a little bit, but we're talking treatment success rates for things like XDR-TB that have gone from 50% to close to 90%. And this is a reflection of that. This is the global global success rate for people treated for TB. The number of newly diagnosed TB cases enrolled on first-line treatment has stayed around the same. Some of the trials that you see with a lot of these regimens have above 90% success rate, but practically in the real world, we see about 85 to 87% success rate. Luckily, the drug-resistant TB, which is the red line on the bottom, that success rate has come up from 50 to 60%. There's some of the changes we'll talk about today are changes in the second-line drugs that we use, and there's been some major changes. And so some of this, I think, is being pulled up by that, but not everyone has transitioned to some of the new US recommendations. So I think that number will continue to increase once people start adopting, and especially countries are able to afford and roll out treatment using some of the regimens I'm about to describe. Before I talk about the regimens, just as sort of like a basic recap, I apologize if this is everyone's familiar with this already, but I think it's helpful to just know sort of what the bug is, have some familiarity with it. That way, when we talk about the treatment and so forth, we have some sort of context in terms of what we're treating. Mycobacterium tuberculosis is oftentimes called MTB. It's an aerobic, non-motile bacillus. The reason it was so hard to identify was because it has this waxy mycolic acid layer in the cell wall, component in the cell wall. And so it is impervious to Gram staining, and that's why acid-fast staining is used. There's the Ziehl-Neelsen, which is, I think, what a lot of us are taught about, which is a hot reaction, whereas I think a lot of times nowadays, most people use the Kinyon stain, which is relatively similar, but doesn't require heating. And then there's also fluorescent methods. These all can be used to identify the bacillus, but it's a hard bacillus to identify, even with with the staining methods. One problem with it is, when we'll talk a little bit about the diagnostics, but when you have smear, it's a very low sensitivity test. And so oftentimes if you put it on you get some sputum, you put it on a slide, sometimes the sensitivity will be about 50%, depending on the burden of disease that they have. And then when you put it in culture, it's a very slow grower. So most things like E. coli, you could replicates in around 20 minutes. Some of them are much faster. But compared to those bacteria, we're talking about basically a day for replication. So we're talking about weeks until we can sometimes have positive cultures for MTB, unlike other bacteria. This is the kind of there's a lot of discussion about where MTB came from. The important thing to know, I think, is that MTB lives within the MTB complex, and this includes other species, M. africanum, M. microti, Kennedy, but I think the one probably a lot of us will want to remember is the M. bovis, which is also in the MTB complex. And the reason I say this is because a lot of times we will have tests, including molecular tests like the expert, which tests for MTB complex, even though it's the way it's discussed as a test for MTB. And so you could have a positive gene expert, which is positive for M. bovis potentially. So it's just important to know that those are MTB resides within this group. And then Mycobacterium leprae is, or Hansen's disease, leprosy is sort of its own thing. Then everything else is considered an NTM, which is not the focus of today, but is also important to know about. The human reservoir is the only natural reservoir for Mycobacterium tuberculosis. I think we all know that it's spread by pulmonary droplets primarily. And then around 85% of disease is pulmonary, probably higher than that, but that's a number that's commonly cited. but you can have non-pulmonary disease in almost any organ you can think of. Spinal disease, pus disease, you can have joint disease. Scrofula was also called the king's evil because there's the thought that a monarch could touch someone and cure them of it. And in fact, there are depictions in paintings and other places of monarchs seeing sickly individuals and touching them, believing that they could all be cured. So again, kind of an interesting historic piece of information, although of course it didn't work. And then of course you have meningitis and then infection of all these other sites. And I think the hard part really with TB, and this is what we're going to get into, is diagnostically it's extremely challenging. So it relies predominantly on three things: the diagnosis of active TB, clinical signs and symptoms, microbiological diagnosis, which is going to be smear, culture, and then, well, we oftentimes use it, but it's not always available, molecular assays, chest imaging if it's available, and then for latent TB, things like quantiferon or skin testing like a PPD. Treatment is also tough because oftentimes the regimens require multiple medications for months, and many of these individuals need to be isolated for public health reasons. They need to have directly observed therapy, which is a burden on the public health system. And adherence can be an issue, especially if directly observed therapy or personal, people's lives get in the way. And so it's just a very, very tough disease to diagnose and then to treat, which is why I think it's been such a challenge to eradicate. So let's talk about diagnostics. And this will be relevant, especially in terms of when we get to what's coming in the future. Let's just start with sort of what we probably all use. For latent TB, we use the interferon gamma release assays. Quantiferon TB is the product almost everyone uses these days. That is a blood test. The nice thing is it doesn't interfere, it isn't falsely positive in young patients with BCG vaccinations, but there's also the skin test, which has been used for a long time and also perfectly acceptable. These only test to see if you've ever basically immunologically seen TB, so they just note exposure, but once they're positive, really, despite people's best efforts to use them for treatment response, etc., they're really only useful for noting that someone has seen TB. Not good for active TB, and even for LTBI, it's really hard to say whether it's even as sensitive as we think it is. I think a lot of the estimates have put it in the 60 to 80% sensitive and 60 to 90% specific range for LTBI, but that's really tough to say because keep in mind, these are the tests on how latent TB is determined. So, there is no reference standard, gold reference standard to compare these tests against. For active TB, we don't use these methods. I mean, people use them just to help sort of risk stratify, but really it's not correct to be using things like quantiferon for active TB. Instead, we use sputum smears. You'll see that 3 of these are usually collected, usually around 8 hours apart. And the idea here is to increase yield. But even then, the sensitivity and specificity, especially the sensitivity, is quite low. As I said before, it's about 50%. It's 95% specific, although some of this is the reader who's looking at the slides and how familiar they are. Note that whenever you have a smear, of course, this could be TB, but this could also be NTM, for example. So we rely frequently on culture to make that determination. The problem with this one, as I said, is it takes 6 to 8 weeks. And even though it has some benefits in terms of speciation, helping with drug susceptibility testing, keep in mind that almost 1 in 5 of active TB cases are culture negative. And so it's not, even though that's considered a gold standard, and there are many cases that will be, true TB infections and have negative sputum cultures. And I'm talking about pulmonary TB, not just extrapulmonary TB. So what we're seeing quite a bit of use of, and certainly I think a lot of us who have seen patients have, of course, used this, but worldwide, the most adopted molecular assay has been the expert MTB-RIF assay made by Safiad. And so this detects the presence of MTB complex. Note that there's no species differentiation, although in most cases, we sort of assume this to be MTB as opposed to M. bovis. And it also checks for rifampin resistance. If you're ever looking at the results from this, the reason why it has these probes A to E is that there are 5 probes that are bind to different parts of the 81 base pair region of the RPOB gene, which is the gene that encodes for resistance to rifampin. And so whenever these drop out, or they're missing on the PCR, that means that there is a mutation in that region, and that is basically indicates that there is likely rifampin resistance. The sensitivity of this is pretty high. It's around 70% with one sputum sample if it's a successful, true, like deep sputum. And then it goes up to around 95% if 3 sputum samples are collected. And again, the specificity is usually called 99 to 100%, depending on whether you're talking about MTB complex versus MTB species. Please note that there are many, many, many other molecular assays that exist. There are urine lamb study assays, etc. They are all seeing some use usually, but they just have had less uniform uptake compared to the gene expert. So those are all valid and kind of an area of active contention between different companies are vying to have their products come to market and gain more widespread use. But the big investment costs come with sort of the infrastructure to deploy these assays. And so I think, not many places don't use the gene expert, and places that do, oftentimes there has to be a good reason to use something else as an alternative. For example, urine assays are great because if they were sensitive enough, because you wouldn't rely on getting sputum, but you have to make that sort of investment. We oftentimes use things like clinical symptoms and chest x-ray to add to aid the diagnosis. Almost never do you use one thing by itself, just because specificity is quite low. There was a review that was kind of interesting to read that resulted in a high sensitivity, 93, 98%, if there were symptoms and chest x-ray scoring systems, but the specificity fell between 35 to 50%. Oftentimes there could be things like malignancy, pneumonia, other pulmonary disease. There's been some work, and this is what the picture on the right is, of machine learning, which is basically an image here shows that there's this x-ray on the left. The ground truth is what a radiologist is reading. The grad cam is this machine learning algorithm, which highlights what it sees. And then there's this predicted class of score, which basically shows the difference between what the computer is reading and what the radiologist read. And the idea there is to highlight things that maybe the radiologist didn't see, so they can go back and double check it. So this is an area of investigation, but not yet, certainly not yet used practically, I think, in most cases. Chest CT has a slightly higher sensitivity. Specificity is still pretty weak. And PET CT is very interesting. They may have some use, but they're expensive and really not practical for most cases of widespread treatment. PET CT has been used in some trials, especially some sort of landmark trials, because it's been used to identify individuals who are near the beginning of treatment and then the response to treatment, and predict if they show ongoing activity and sort of uptake in areas, whether there will be relapse. The problem is the specificity remains really, really low. And so you have to be pretty confident that someone has TB to use it reliably. And it's so expensive. Taking multiple PET CT scans is so burdensome that it practically is not used outside of a set number of trials. So that brings us to sort of treatment. And keep in mind, I'm talking about all these different diagnostic techniques. Usually most countries will use, we'll use quite a number of them, but most countries will use things like smear, culture, if it's available, but sometimes not. Expert if it's available, but sometimes not. And then many patients will be started on treatment regimens empirically. That is, the TB prevalence is high enough that if someone has the signs and symptoms and one piece of workup that is consistent with TB, they'll get started on these regimens. And so let's talk about some of these regimens and the standard regimens. Now, keep in mind, the regimens that we've been using are quite old, have been around for a while. The latent TB regimens were updated in 2020. So this is actually sort of a recent change compared to the prior regimen and the guidelines which were published in the ATS in 2000. So, the 20-year update. And this is kind of a big change. now, as opposed to isoniazid monotherapy, which I think a lot of people were using and practically still may be necessary for some patients due to drug-drug interactions, there's been a big push to adding rifamycin-based therapy, so rifampin or rifapentine, and we can get down to these, 4 3-month regimens that are quite effective. So it's, this is a pretty big progress. 3-month 12 dose therapies compared to 9 months of therapy is an extraordinary step forward, and the likelihood of someone completing treatment is presumably a lot higher. Practically speaking, I see a lot of patients who have drug interactions with the rifampin or rifapentine in my clinic and in the own clinic, and so I tend to end up, I talk to patients and kind of talk about switching their ART. Many patients are resistant to switching the ART if they've been on a regimen for a while. So inevitably, some patients will be treated with isoniazid monotherapy. But the nice thing is that there are options that are much shorter, and many, many patients are actually eligible for it. So this is the first one is basically patients, non-pregnant adults without HIV. The second is non-pregnant adults with HIV. Just keep in mind that it's just a small modification, but there are just a constriction of what is recommended. And keep in mind as well that the rifampin, rifapentines, you still have to kind of keep determine whether the ART regimen will have drug-drug interactions or not. And then for pregnancy, the main dropout here is going to be the rifapentine-based regimens, because rifapentine has been studied in pregnancy. So right now, not recommended. But overall, relatively similar regimens are available. How about active TB? Now, this is something where we've seen some pretty big changes recently, which is, I think, really exciting. So this is a summary of what different regimens are available, but basically these are just different ways of regimens of RIPE. And so this is the 6-month isoniazid, rifampin, pyrazinamide, ethambutol regimens, and these have been stable for almost 40 years. So we've made progress. I'm not going to say there hasn't been progress, but really in terms of recommended guidelines, recommended regimens, this has been unchanged for a long time. And I think a lot of us know that this is 6 months of treatment is hard. Also, the intensive phase, especially with 4 drugs, can be tough for many patients. And the adverse effects from many of these medications are also challenging, especially if someone suddenly has liver enzyme elevations or other side effects. So it's a good regimen, but obviously there's a push to try to make it simpler, make it faster, as you might imagine. One thing that's kind of interesting that let me skip this. So the point of treating drug susceptible TB, there's been a great interest in shortening the regimen for the treatment of drug susceptible TB, like I mentioned. And there have been many, many publications over the years which have not really panned out. So I'm going to not go through them all, but highlight a couple of them. The moxifloxacin-based regimens for 4 months were looked at, ultimately not as good as the control or standard treatment. This one looked at high-dose rifapentine and moxifloxacin-based therapy. It was non-inferior in the 6-month treatment, but not in the target 4-month treatment group. So again, not much of a success. This was a 4-month gatafloxacin therapy, which kind of unfortunately ended up leaning more towards the control group. There was, because of the error margins, had some overlap with perhaps being non-inferior, but overall this was taken to be probably inferior or at least questionable compared to the control. And then finally in 2021, there was a new study that came out of the ACTG group, and this looked at 4-month rifapentine regimens with or without moxifloxacin. And so, there's the control group, there's the rifapentine by itself, and then there's the rifapentine moxifloxacin regimen. This is basically, this regimen is where the rifampin in RIPE has been replaced by rifapentine, and the ethambutol has been replaced by moxifloxacin, which is then continued. And so the results are shown on the right, and you can see that the rifapentine alone group did worse than the control, but the rifapentine moxifloxacin group was non-inferior. And they concluded that the 4-month regimen was non-inferior to the standard 6-month regimen. And so I think this was kind of like the big breakthrough that a lot of people were looking for. 4 months versus 6 months doesn't seem like a lot, but 2 months off of therapy is, I think, pretty major, considering, in real life, if 2 months of your life. And so in 2022, the CDC added a recommendation that this 4-month rifapentinoxyfloxacin regimen could be used. And again, there's an intensive phase and then there's a continuation phase. There are some recommendations in terms of limiting this to certain individuals who have no contraindications. The other challenge is that some of these doses need to be done under directly observed therapy, but like most of the treatment we see in the US, at least part of it, is under directly observed therapy. And so the goal is that this may have more uptake. Practically, have I seen this regimen used? I've never personally used it or seen it used, but presumably this will now start to be and used more often in terms of clinical practice. But this is a major, major change. Again, this is the first new in the US recommended regimen in the last 40 years. There's also the thought that maybe we can get it even shorter. So 4 months is good, but how about 2 months? So there was this truncate treatment trial, and I want to mention this because this just came out in the past couple months. And this is one of the trials that I think may actually see some discussion about being put into clinical practice. There are many that I see sort of on the line, and I don't know if this one will, just because there's some issues I'll bring up in the end, but I do think it's something that might find its way towards the guidelines. So basically this looked at individuals and was trying to prove a non-inferiority trial of a 2-month regimen. Now that's a bit of a simplification. It's a 2-month regimen strategy, which I'll describe in just a bit. But basically they were evaluated by looking at symptoms, positive chest x-ray, or having, and then the main important thing is that they had an expert MTB RIF. And this was really crucial because the MTB had to be positive. So someone basically molecular diagnostics confirmed tuberculosis, but was negative for RIF resistance. And usually we use RIF resistance as a marker for drug resistance in general. So if it's RIF susceptible, we generally consider it as generally susceptible. And RIF resistant, that could mean one or more other resistances can be present. The thing that I really dislike about this study as well is that initially they excluded all patients, people living with HIV, and then halfway through, well, really 3/4 through the study, they changed their criteria and they allowed persons living with HIV to be enrolled, but ultimately ended up enrolling no one who was living with HIV. So I think that's a that's a limitation of the study for sure. The way I would, I have this sort of like kind of semi-frowny face question mark type of speak, and I'll kind of get to why in just a bit, but I tried to simplify the regimens in this little table. The top is the control. This is just the 6-month treatment, standard treatment. And then they looked at these different high dose combinations of rifampin and linezolid, or rifampin and clofazimine, or rifapentin and linezolid, or bedaquiline and linezolid. And the important thing here is that they do 8 weeks of this combination and plus INH, PZN, and ethambutol for all of these. So it's not just these 2 regimens. Those are the 2 unique drugs plus the 3 others. And so it's really sort of, it's the rifampin part that's being replaced or modified for all of these. And the reason why it's called a strategy and not really a 2-month regimen is that even though they say it's an 8-week regimen, the idea is really a treat, monitor, and then retreat if relapsed strategy. And so they look at clinical disease at 8 weeks, and if they have any issues, they extend it through week 12. And if there's still clinical disease at week 12, they just switch someone to the standard treatment to complete 24 weeks. And then in the study, they looked for 96 weeks for outcomes and relapse. But people need to be monitored very closely, because also, if at any point in this, if someone relapses, they are retreated with at least 24 weeks with the standard regimen, depending on the individual's resistance profile. And so the goal here really is, it's sold as a 2-week regimen, but what it is it's a let's try 2 weeks, and then it's an adaptive treatment depending on whether they're responding, non-responding, or if they have relapse. The important thing to know is that 2 of the arms got the numbers in bold on the left are the number of people they actually recruited into the arms. And you can see that they're a lot lower for those 2 middle groups because those were cut. They just weren't hitting their recruitment target. So they decided to cut the 2 of them. They ended up enrolling 675 participants. And this is kind of a summary that is available on NEJM's website. You can see that standard treatment and bedaquiline linezolid groups kind of had pretty similar in terms of basically unfavorable outcomes, whereas the rifampin group didn't fare quite as well, but and all of them had pretty similar grade 3 or 4 adverse effects. So the conclusion is that this strategy involving this 8-week bedaquiline regimen was non-inferior with no apparent safety concerns. So like, why am I a little concerned personally about this? And I think it's because of some of the work that our lab is doing, and so that's maybe a bias. But when you go into the actual supplement and all this other data, 98% of the standard arm completed treatment, 91% of these strategy arms completed the treatment, and in the initial treatment, 6% had to switch from the strategy arms or the short courses to the standard treatment within the initial treatment. So maybe that's not so bad, right? Maybe 6% had to switch over. That's reasonable. It's part of the strategy. The part that kind of I think starts getting a little more concerning to me is like how many people were treated, stopped, and then retreated, and almost less than, but almost 20% of the truncated strategy arms had a second treatment course. The bedaquiline linezolid group, which is among the lowest, and that's the kind of the one we're looking at, that was 13%. But that's still in 1 in 7, 1 in 8 are getting retreated with a second treatment course with the standard treatment. And so this is the primary outcomes table. I'm not going to go through all of it, but again, this is kind of the information I showed before, where the bedaquiline linezolid, unfavorable outcomes are relatively similar or non-inferior to the standard treatment. The part that I think is kind of interesting is secondary outcomes, where we look at the total duration of treatment. This is, what did they actually get, including extended treatment times, retreatment, et cetera. And practically with the bedaquiline linezolid group, it's being sold, I think, the way I feel this article comes across is this is an 8-week treatment, but in practical terms, really it's around 3 months of treatment instead of 2. So it's cutting the treatment in half, but it's not quite, exactly two months. And when you're thinking about 3 months versus 4 months with the other regimen we just talked about, how big of a difference is that, and is it worth some of the risks with this regimen? Now, the participants did feel that they preferred the 2-month regimen treatment. Now, my bias is that they all underwent the 2-month regimen treatment. They didn't undergo the 6-month regimen treatment. So it's kind of, that's what they got. So anyway, the other part that's interesting is the adherence was actually a big argument with shorter courses, is that we should try doing it because adherence will improve, but adherence was pretty similar across the board in all of the treatment groups, including the control group. The part that again, these numbers are tiny, so I don't want to make too big a deal out of it, but the idea that scares me when this is applied to a major, like a national or international population, in this study, 2 individuals had acquired drug resistance. Again, we don't need to go through them, but they had resistance to bedaquiline and clofazimine, and ultimately they were treated with standard treatment and had success. One of them had missed a lot of doses, so there may have been some component of that, but the second individual basically had, per protocol treatment and still had to have retreatment after having relapsed. And the scare for me is that, when you expand this to a large population, there will be a lot of people who will be exposed to these drugs, come off of treatment, be monitored, have to be re-diagnosed as having active TB, be put back on treatment, and potentially increase resistance to these drugs. And I just want to highlight a little bit why that's a problem, but this is just a summary of what I just said, so I'll skip this. But the issues for me is that, bedaquiline and clofazimine have very long half-lives, and this is probably why a lot of these individuals develop resistance, is because after they finish their 2-week regimen, if they're considered okay cured, which we have very poor ways of diagnosing, they are living with bedaquiline and clofazimine after all the other drugs have stopped, and that's why acquired resistance is, my guess, is occurring in these individuals. And the big problem for me is that we don't really have great tests for bedaquiline, linezolid, clofazimine resistance. So, right now, this is all based on the expert MTB RIF. And this is really dependent on using RIF resistance as a surrogate for multi-drug resistance, even though they're not making the claim that this treats all, drugs all drug susceptibility. They're just talking about rifamycin drug susceptibility. I still think that's kind of the point that they're trying to get at. And the reason why I'm worried about this entering, you may see this come into the guidelines, you may see this discussed a lot in the future just because it just came out. But we have very poor or non-existent phenotypic DST tests for a lot of these drugs that we're talking about. They exist, but they're just not as reliable or thought out in terms of having really well understood critical cut points. And so the phenotypic DST testing is tough, but possible. And then genotypic testing is a lot weaker right now for a lot of these drugs compared to others. We don't know all the resistance markers that will indicate resistance or confer resistance. Like the other thing too is they're not all confined to, for example, small regions of the genome. Many times there are multiple genes involved. So unlike, for example, rifampin RPOB, where you just have 81 base pair region with multiple well understood mutation points, it's a lot more complicated to come up with a way of testing this. And so, and I'll talk about that in a little bit, but sort of as a segue to what I'm going to talk about right now is, the authors admit that this is a tough sell to some extent because there is that limitation in terms of people being exposed to these drugs coming off treatment, and we don't really have a good way of knowing if treatment has been successful or not. And so they mention they specifically cite a point of care non-sputum dependent biomarker of disease activity such as blood RNA signature could well with this strategy. What they're referring to is this 3 gene signature that came out of the Cottrey lab at Stanford. This was Sweeney and the rest of the group. They now have a company, Inflammatrix. I'd have to look up the name, but they have been working on a lot of. They're sort of a big data group. They look at heterogeneous data. They look at combining all that information, and they look at immune response. And this is a 3 gene signature, which I'll talk about in a little bit, but this is a blood-based test that helps look at host response to TB, kind of like interferon gamma release assay, but more sophisticated in some ways. And the idea here is that this may be helpful in looking at treatment success. And there's also a new 9 gene signature. An abstract has been put out, but the final paper is not out yet, which may be promising in this regard as well. I'm not sure how much I'm allowed to talk about that. So if you have questions. Oh yeah, go ahead.
I'm just going to give you a time check. It's 8:49 now, so just so that you have some idea.
Okay, I'll be quick and kind of move through the rest of these relatively rapidly so I can take some questions. Okay, so let's talk about drug, and this is the second part that comes up that I think is concerning, is that we're talking about using these medications like bedaquiline, linezolid, et cetera. And these are medications that right now are relatively reserved for drug-resistant TB. So this is a pretty big change, relatively recent. But in 2022, the guidelines changed based on multiple trials. And basically they looked at new and repurposed drugs for multi-drug resistant TB. And just to keep things moving, let's just say that before 2021, there was this certain there are certain definitions for drug resistant TB: multi-drug resistant, rifampin resistant, extensively drug resistant. In 2021, they changed that, so now there's pre-XDR and XDR, which is relevant because the whole treatment approach for drug resistant TB has changed to some extent. It used to be you'd have injectables, aminoglycosides, again, kind of like the later aminoglycosides, less so streptomycin recently, but things like caprimycin, kanamycin, amikacin, those are no longer recommended, with a couple of rare exceptions. And instead, things like bedaquiline and linezolid are being recommended. And there's the 6-month all-oral regimen, bedaquiline, protominid, linezolid, and moxifloxacin, which can be now used for cases of drug-resistant TB, and in some cases, XDR-TB if appropriate. And the reason I mention that is because this is a huge change from going to massive amounts of pills, injectables, for up to 18 months or longer. That was the standard of treatment. Now we're talking about going from 18 plus, 24 plus months to 6-month all oral therapies. But again, this is reliant on these medications that I worry are going to see widespread use and maybe resistance, especially in a world where we're not really, I think, well equipped yet to detect that resistance. I'll skip this. This is just sort of the summary recommendations because it's kind of complicated in terms of who's, who can get which of the treatments. But I think the blood-based assays are really cool. Again, we don't have much time, so I'll just be super quick about this. This is the Cotry 3-gene signature I was talking about by Sweeney et al. This basically identified 3 hosts. This is human genes, and their upregulation, downregulation profile creates a signature. And for active TB, the sensitivity specificity against healthy controls was 93% and 97%. And then for LTBI, a little lower, 88%, 95%, but still pretty darn good. And now it's actually being operationalized and put into a product that's undergoing testing. This is the Cepheid Expert MTB host response prototype or cartridge. The cool thing about this is that this is basically, you can run this on the same things you're running the current Expert MTB riff on. So you don't need new infrastructure to deploy this. And so I think it's pretty promising, and it's cool that it's using the host response in this way. And again, there's this 9-gene signature that may or may not see new use. This is a lab that we've worked with, but this is kind of cool because it's a CRISPR-based MTB cell-free DNA assay, and they've looked at adults, but especially with children where TB diagnosis is hard. They found methods to use CRISPR-Cas12 to identify very, very low levels of circulating MTB DNA and make a diagnosis from blood. Which is cool. And then the last thing is in our lab, we're working on this thing called the BET or BETA assay, which looks at this MTB specific CFP10 antigen by running, I won't go through all of it just for the sake of time, but basically you put serum or urine samples onto an electrode, and you basically run a current through it. And you can see based on CFP10 binding, whether it's basically an ELISA-based assay, whether there is infection or not. The cool thing here, again, this is kind of hard to interpret, but basically every single individual who had TB was confirmed, or basically individuals who had TB were compared against negative, very well understood negative controls, and from both serum and urine, all individuals who were tested were identified correctly. Looking at people who, so this is like C1, C2, C3, C4. This is these are all different individuals, different cartridges, but basically with treatment, you can see these numbers come down. So it may be also able to use either blood or urine to see if there's a treatment response. And then for phenotypic DST, I was kind of talking about how this is a big problem. There's this, the New York State Department of Health at the Wadsworth Center does whole genome sequencing on all of their samples, which is crazy. It's pretty awesome that they do that. But that's not going to be a worldwide solution. So there's this big focus on trying to use targeted next-gen sequencing, which is basically sequencing, but on a much sort of smaller scale. It's more affordable and also more focused. And it seems like there might be some success there. So anyway, that's an area for the future. That one's quite nebulous. So we might see papers around it, but this is something that the WHO and things like FIND, which works with the WHO, are actively looking into. I can talk about all of these things, but I do want to stop right now to take questions, just because I know we're running right on time, or right at the end of time.
Great. Thanks, Rehan. There are a few comments and questions, and I'll try to go back through it. I think Robert Dice had put in a comment about resource limited settings, about bedside ultrasound can have high sensitivity, and the urine assays you mentioned are also point of care.
Yes, absolutely agree. And I think that's why they're seeing some use, certainly. I just don't think they've been, and so there's definitely a place for a lot of them. It'd be nice if there was something that was available that was more standardized in the sense of high, really good test characteristics, and kind of easy to deploy and reliable. So there's definitely a place for all of them. I think we're going to see who sort of wins out ultimately in terms of just being the best test. It's hard to compete right now with the gene expert.
Yeah. Scott Latender wrote here, in truncate TB, could they predict who was likely to respond without substantial AEs so that the 8-week therapies could be targeted to those most likely to succeed?
I don't know if Dr. Benson may know more about this, but and maybe that's what her response is to, but I don't I don't think that they had that information, but
Yeah,
yeah,
it
there was
hasn't
a high
been
risk and low
published.
risk. Sorry, go ahead.
It hasn't been published yet, but part of that trial had an extensive modeling component, and they are doing secondary analyses of the baseline data to look at both the characteristics of the TB itself, like cavitary versus non-cavitary, and some of the other signs and symptoms of TB, as well as the laboratory analyses done at baseline to look at factors that would predict both the response to the shorter course and adverse events. So that's an analysis that's underway.
And I think, even the publication that came out, there is a sort of high risk for relapse and low risk for relapse index that they put in one of the tables, but that would be really, I think I will definitely keep an eye out for that secondary analysis, because that was something that could solve a lot of issues. I'm looking at Dr. Dice's comment.
Mm-hmm. The apples and oranges for clinical practice, but I think it's worth noting that 8-week regimens of linezolid and in truncate TB didn't have significantly more adverse events than the other regimens for everyone who's afraid of linezolid and oral antibiotics.
But then Shannon pointed out it was a lower dose, so asked and answered, Your Honor.
Although and just in response to both of your points, there are numerous studies looking at 600 milligrams daily of linezolid now, and several studies that are looking at sort of two-stage dosing schemes for linezolid, with 600 milligrams twice daily up front, or 1200 milligrams up front, and then lowering the dose either through intermittent dosing or lowering the dose to 600 milligrams a day. So don't feel bad about that. There's lots of work being done with linezolid dosing. And I think the point is well taken, that there's much more in the way of linezolid dosing being studied and being used in clinical practice out there for prolonged periods of time, with obviously some people experiencing some of the adverse events that we are aware of for linezolid, but many people getting through full courses of therapy without having trouble. And so I think it's a good drug, and and if you're monitoring carefully for adverse events and responding appropriately, it's really become one of the cornerstones of therapy for TB.
All right, and then I think there's a comment at the bottom. I presume that's Daniel Park about linezolid 600 dailies, the recommended WHO dose for treatment of resistant TB, and also mentioned a study showed equivalent to 1,200 milligrams with less AEs. Any thoughts?
I agree. Linezolid, I mean, in general, I think Dr. Benson, of course, had it right on the mark. In general, I'd have to look back at the Xenix study. I did look at it earlier, and I can't remember off the top of my head. I think that's correct. I do remember in general, a lot of these studies, where they're looking at different linezolid doses, there does seem to be, a drug, a dose-related adverse effect in terms of linezolid associated adverse effects, like an increase as you increase dose, with some exceptions, but a lot of times people could push through it in terms of hematologic, especially. The part that I guess in my concern long term would be things like neuropathy and so forth, but again, these are all, I think everyone's trying to find the lowest tolerable dose that has a good outcomes, and again, I kind of agree with all of the points, in the sense that I think linezolid is a kind of a scary drug for many of us, myself included. But in the case of TB, TB is a scary disease, and these are actually better, it's better tolerated than I think a lot of us would assume off the top of our head for that duration of treatment.
Great. Any other thoughts, comments? Anyone want to unmute or?
I think, Dr. Park also mentioned that I have a hard time imagining the role of Daquilin for drug susceptible TB, given its critical role in eliminating the use of injectables. General desire to observe it for resistant TB. I absolutely agree. I think there may be a different future where that changes, but right now where the paradigm has shifted so much to BPAL in terms of where we want to be going. If we lose those drugs on drug susceptible TB for potentially like a marginal benefit, like let's say like a 1 month benefit, I don't know, the costs ultimately may be too much. So I'm nervous about that too.
Connie, do you want to make your last comment?
No, I was just finishing up
Okay.
what I'd previously said.
Got it. All right. Well, I think it's 9:01, so I'm going to go ahead and end it here. But I want to thank Rehan for an excellent overview and kind of update on some of the newer technologies for diagnosing TB. I think it's fascinating to kind of hear what's new, and hopefully we'll see some of these in our new guidelines perhaps in the future. Thanks everyone for being here and participating. Thanks again, Dr. Syed, for a wonderful talk. So have a great weekend, and we'll see you next time.
Thank you.